Hello, everybody. Welcome. It's 8 o'clock in my time zone, and I wanted to, we're Central Time Zone here in the United States, and I wanted to thank everybody for joining us for our MPM Hub Clinical Trials Club webinar. In this event, we're going to be talking about the data around Navtemadlin, or KRT-232, versus best available therapy for patients with relapsed or refractory myelofibrosis. And I'm joined today by Dr. Haifa Al-Ali, who's a professor of translational oncology at the University Hospital of Halle in Germany. Next slide. So as I mentioned, we're going to be talking about what's called the BOREAS trial, which is the nickname for this study, but really want to get into all of the preclinical and clinical data available so far on this novel agent. Next slide. Next slide. As I mentioned, my name's Laura Michaelis. I'm a professor of medicine at Freitas in the Medical College of Wisconsin in Milwaukee, and I specialize in myeloid disorders. And Dr. Haifa Al-Ali is a professor of translational oncology at the University Hospital in Halle in Germany. Next slide. So these are my disclosures. None are relevant to the current presentation. Next slide. We do have a little bit of a housekeeping here. First, our agenda. We'll be talking about some overall background data on MDM2 inhibition in myelofibrosis, and then going into an overview of the current clinical trials on Navtemadlin, including key efficacy and safety findings. We'll then have a bit of a discussion about what these trials mean for clinical practice and also Q&A. So we hope that everybody will be able to describe the novel therapeutic target that this drug is aimed at, explain the mechanism of action, understand the safety and efficacy data, and also have a better understanding of the role of this drug in the therapeutic landscape. Importantly, this independent educational activity is supported by Kartos Therapeutics. However, all content has been developed independently by our faculty, and the funders have had no influence on the content of this activity. All right, so I'd like to next introduce Dr. Al-Ali, who's going to talk a little bit about the background and introduce us to this novel agent for primary myelofibrosis. Dr. Al-Ali.
Thank you very much, Laura. Warm welcome from me too. I'm really very happy to be here and share the information with you, and I'm really looking forward for a very nice and interactive discussion. So
I'm just going to interrupt you for 1 second. So we're leaving the pre-test open. You can move it to the corner though and answer, but try and answer before the data is presented. Thank you.
Okay, let's move on. Yeah, these are again my disclosures, and as Laura mentioned, in my case too, none of these disclosures is relevant to the matter which is under discussion today. Next, please. Yeah, Laura mentioned this already. We will discuss first the mechanism of action. Does MDM2 play a role in patients with myelofibrosis? Then we will have a short overview of the already finished and ongoing BOREAS trials, and then the first efficacy and safety data available today. So next, please. Let's start right away with the first topic, the mechanism of action of MDM2. And we would like to have the next slide, please. Yeah, we could skip that. Yes, you know, first of all, we have to remember that normally in normal cells, P53 is usually kept at a very low level to just ensure and mediate cell cycle arrest. And really this low level of P53 in the cells is maintained mainly by MDM2. And indeed, MDM2 is the key negative regulator of P53 tumor suppressor protein. It modulates the activity by several mechanisms, as you could see. First, it inhibits, for example, the p53 transcriptional activity. It really transports it out of the nucleus, and MDM2 tags p53 for proteasomal degradation. This is normal. What happens in cancer? Next slide, please. You know, a cancer cell is a stress cell with a lot of DNA damage. And what happens here, usually in many cancer cells, we have a dysregulation of p53 function, either because of the presence of an inactivating mutation in the TP53 gene, or we do have an overexpression of MD2. In both, by the way, just MDM2 stands for murine double minute 2, just to know for what this abbreviation stands. So either the overexpression or a TP53 gene mutation, they will overcome the p53-driven cell killing. This means that cancer cells get a survival advantage, and so cancer cells could proliferate. And that means that this brings us right away to the rationale for the use of MDM2 inhibitors to be used in cancer cells to try to restore normal p53 tumor suppressor function and thereby assist cells to go into cell death, the so-called apoptosis. Next slide, please. And indeed, one such example of an MDM2 inhibitor is the KRT232, or what is known as Navtemadlin. This is a potent, selective, and orally available inhibitor of MDM2. It has a very strong binding affinity. It can be rapidly absorbed, and it has a relatively long half-life of around 17 hours, which makes it also for the clinical practice and application a very relevant issue. Next slide. How does Navtemadlin work in cancer cells? As we said, Navtemadlin will increase levels of certain proteins that are very important for the p53 function, including p53, but others like p21, and this was one of the questions, by the way, MDM2, and as well PUMA. And you know, PUMA is the pro-apoptotic BCL2 protein. And this happens in a dose-dependent manner. This is interesting to note that the compound does not only work on a protein level, but also on a messenger RNA level. For example, let's look at the p21 messenger RNA affection and increase under Navtemadlin in a dose and time-dependent manner. And as you all are aware, p21 is a really major target of p53 activity, as it links every cell damage, DNA cell damage, to cell death. So, taken together, the use of Navtemadlin will lead to cell death by inducing restoring the p53 function, which will induce the intrinsic mitochondrial apoptotic pathway and restores or stops the growth of tumor cells. Next slide, please. Well, the question now is, what is the role of MDM2 in myelofibrosis? As you all know, TP53 mutations are quite infrequent in patients with MPN, yet we know that the majority of patients, a distortion and a dysregulated p53 function is present. Why is that so? Today we know that through the JAK2-mediated signaling in the CD34 positive stem cells in patients with myelofibrosis, this leads to upregulation of the so-called La antigen. What is the La antigen? This La antigen can recognize specific classes of messenger RNA, including the MDM2 messenger RNA. So it will mediate the translation and then the accumulation of the MDM2 protein. And so we see that in the majority of our patients with myelofibrosis, there is an overexpression of MDM2 in these CD34 positive cells. Next slide, please. So in summary, using the MDM2 inhibitor does have a rationale to restore p53 activity, to drive apoptosis, as we have mentioned, by inducing the intrinsic apoptotic mitochondrial pathway, where the balance is shifted toward the pro-apoptotic BCL2 family members against the pro-survival apoptotic BCL2 members. Pro-apoptotic members, very important for cell death, like PUMA, again, it was one in the questions, Nafta, or again, them. And we know that the poor formers will lead then to the cell death by releasing cytochrome C and inducing caspase 9. So my next question is, okay, we have a rationale. We know that MDM2 is overexpressed in MF patients, but do we have a need for the use of this form of treatment in patients with MF, especially that we are now living in the JAK inhibition era? Next slide, please. The slides do not, yeah. So the answer to this is the next slide right away. The answer is, I think we all agree that the use of JAK inhibitors has completely changed the treatment landscape in many of our patients and improved their quality of life. Yet today we know that about half of our patients do discontinue ruxolitinib after 3 years of treatment, mainly not because of primary refractory disease, but because of loss of response or the so-called relapse. And then we have surely intolerance to the treatment. And we know very well that the prognosis of relapsed and refractory patients to JAK inhibition is really bad and their quality of life is bad. So there is definitely a need to have novel treatments in these patients after JAK inhibition failure. With this, I come to my summary of the first part of the talk. Next slide, please. So MDM2 is a key negative regulator of p53. We know that stem cells in patients with myelofibrosis have an overexpression of MDM2, and that if we inhibit MDM2 in these cells, we could restore the p53 tumor suppressor function and induce cell apoptosis. And we do have an MDM2 inhibitor called Navtemadlin, which has shown to be active in restoring p53 function. And we still do have an unmet medical need after failure of JAK inhibition in patients with myelofibrosis. With this, I will come to finalize this talk and jump right away to the second talk. Next slide, please. But before I start with an overview of the Navtemadlin trials, you know, the title of this webinar is also BOREAS. So I thought maybe we should all just make a small interactive question. What is BOREAS? What do you think? For what stands BOREAS? Next slide, please. I would like to show you the question. Is it an acronym for Beyond Ruxolitinib, Early and Active Salvage Therapy? Or is it part of the name of an energy supplier to symbolize the power of MDM2 inhibition? And believe me, this is not a joke. There is an energy supplier who has BOREAS in its name. Or is BOREAS a strong Greek god of the north wind with a very violent temperature match? Or would you say, I'm not sure? So please vote. I'm really keen to see your answers.
I'm not sure if we'll have the poll answers right now, but I will get them via the chat if they don't appear.
Yes,
and I will fill that in. All right.
Yeah, maybe as an answer, BOREAS actually in the, yeah, we do have
here
it.
they are.
So I'm really very proud of myself because, you know, answer number one, which was now answered by 2/3 of the attendees, was something I thought a long time, how could I use the BOREAS letters to make, this is an imagination, this is something I just imagined. And actually BOREAS stands for blocking MDM2 to reactivate p53 in myelofibrosis, just by the way. But indeed, BOREAS is the name of a Greek god of the north wind, who is very strong and very violent and has a temper that is very active. And this is actually as a symbol to symbolize a new treatment era in patients with MF. So just as an answer to what is BOREAS. Next slide, please. So BOREAS has two parts. We have the phase 2 trial. This is the KRT-232101 trial. This was, as I said, phase 2, and an open label trial for patients with either primary or secondary myelofibrosis who were refractory and or relapsed to JAK inhibition. Mind you, this is very important when we look at the data to remember that in this trial, no patients who were intolerant to ruxolitinib were allowed to be included. This means the data in the trial was only for patients who were refractory or relapsed to JAK inhibitor therapy. Next slide, please. And as I said, in this trial, primary or secondary myelofibrosis after failure of ruxolitinib, patients have to be wild type for TP53, no mutated TP53, and patients had to be intermediate or higher risk DIPS score. Patients were then randomly assigned to 4 groups, to 4 cohorts actually, with different treatment regimens and durations. I will come to that soon. The primary endpoint of the trial was spleen response from baseline to week 24, and spleen response was defined as at least a 35% reduction in Mills volume by MRI by week 24. One of the key secondary endpoints was the improvement of at least 50% of the total symptom score at week 24 compared to baseline. Next slide, please. And then this was immediately attached to the phase 3 trial, which is now recruiting and active. This is a global phase 3, as I said, trial, randomizing patients again with primary or secondary myelofibrosis after failure of ruxolitinib. Again, I stress the point failure and not intolerant to ruxolitinib, to be treated in this trial. Next slide, please. Again, the myelofibrosis refractory or relapsed patients had to have TP53 wild type, refractory resistant to treatment, and the randomization was done 2 to 1, 2 in arm 1 to 1 in arm 2. Arm 1 was treatment with Navtemadlin, 240 milligrams, 7 days, that means 1 week, then 3 weeks off in a whole 28 days cycle. Again, primary endpoint was spleen response, again at week 24, again at least 35% reduction of spleen volume by MRI. And another, again, key secondary endpoint was at least a 50% reduction in total symptom score, again at week 24. Next slide, please. The main inclusion criteria of the BOREAS phase 3 trial, I will not read them, but I just want to stress the difference to other trials, because, you know, the definition of refractory or relapsed is, you know, is quite arbitrary and sometimes very difficult, and we don't have really strict criteria sometimes. But in this trial, really, relapsed or refractory have stringent criteria that are really quite hard, so that we could really, when we get the results, hopefully say something to patients who are clinically relevantly resistant or refractory to prior JAK inhibition therapy. Next slide, please. And with this, I actually will conclude the second part, just showing that, as I said, the phase 3 BOREAS trial is actively recruiting all around the world, with many countries participating in this trial. Let's now jump to the main efficacy and safety data available to us to date, because I think the data from the phase 2/101 trial are very important for the phase 3 trial. Next slide, please. Yeah, so exactly, that's what we have learned from the phase 2 trial. I will present the data of the 3 first cohorts, and this is a total of 82 patients. who were included in these 3 cohorts. And just to make things short, the best results and the most safest and most effective regimen for treatment with Navtemadlin was actually the 240 milligrams, 7 days, every 4 weeks. And we will see that later. If you just look at the patient characteristics included in this trial, and I think it is always very important to look at patient characteristics to, put results in the right context. You see the median age is 69 years, and this is the typical age of patients we see at least in Europe and in the United States with myelofibrosis. Many of these patients were intermediate to and high risk, again, not by IPSS, but by DIPS, the dynamic IPSS risk score. So these were really advanced disease patients. The majority were refractory and relapse. As I said, no intolerant patients were allowed to be included in this trial. Around 25% of patients had platelets below 100. Mind you, this is also important. Patients with platelets below 50 were not allowed to be treated with Navtemadlin. This is again very important to remember, that patients from platelets 50 and above could be treated with Navtemadlin. And again, what is quite important, and this is something I found a very positive aspect, and we could discuss about that in this phase 2 trial, there was no required washout phase for the JAK inhibition before starting with trial treatment. And all other trials always require a minimum of 2 weeks up to 4 weeks of washout of JAK inhibition before starting with a trial medication, because you are all aware, because of the rebound and the flare we might have when we discontinue JAK inhibition with the spleen and the symptoms, which will or might confound trial results. For the sponsor, this was not a very good thing, but from a medical point of view, it was very, very comforting, a comforting issue, because we all know how patients suffer, even if we believe that they are refractory or relapse to JAK inhibition. And if we discontinue these treatments, patients really feel very bad. And we do have many issues in this washout period. So here there was no washout, and this is important when we look now at the results. Next slide, please. So this is response. As I said, this is a phase 2 trial, and the spleen response, if we look at the spleen response overall, we have a spleen response of at least a reduction of 35% by MRI from the baseline in only 16% of these patients. But as I said, the results of this trial were actually confounded by the lack of the washout, because, when the baseline MRI was done, patients were still on JAK inhibition. And then day 1, they started with Navtemadlin. And in the meantime, until MDM2 inhibition was working, patients had a huge increase in the spleens. And so if you look at the 2 groups separately, the ones who were on ruxolitinib at the start of, or day -1 prior to the start of MDM2 inhibition, the response in these patients mounts up to 30% compared to actually 0, especially at week 12, for patients without a washout period. Regarding total symptom response, at least 30% of patients had at least a 50% reduction at any time while they were taking the medication compared to baseline. Next slide, please. Interesting is, and again, we have to be careful, these are phase 2 data, still limited number of patients, but there are some interesting observations. There were some interesting changes in biomarkers of the disease, for example, the allele burden. And indeed, in 30% of patients, there was at least a 20% reduction in the allele burden relatively early under treatment with MDM2 inhibitor Navtemadlin. And what is interesting is that it seems to be a clinical correlation between the spleen response, the symptom response on one side, and the reduction in the allele burden. As I said, small number of patients, but an interesting observation. Next slide, please. To me personally, this is one of the very interesting findings of this trial, namely the dramatic reduction in the circulating CD34 stem cells when treated with Navtemadlin. And you can see that really after 1 week, actually, patients, let's say with blast 7 or 8%, a week or two later, in many of these patients, you will see no blast. And we could see that we have actually a reduction of almost 90%, particularly when patients are treated with 200 milligram per day for the 7 days, every 4 weeks. And this is really dramatic, and it is sustained up to month 6. This is the median follow-up time of this trial. And again, interestingly, it is not just the lab finding. There seems to be a correlation between this reduction in blasts with clinical benefit in terms of spleen volume reduction and total symptom improvement. Very interesting and very dramatic finding. And the same is true for the LDH, which we observe in our patients, which again normalizes quite rapidly and dramatically in many patients. Next slide. And again, we have data to cytokines. I just chose TNF-alpha as an example, that again, we have a good reduction in cytokines under treatment, particularly again in the 240 milligram cohort. And again, there seems to be a correlation between the reduction in cytokines, which is actually no surprise, to the clinical response in spleen and in symptoms. So these are very interesting findings, and there are some preliminary findings about bone marrow fibrosis, although I am always very cautious about these findings because they're still much too early and we need much longer time to really interpret these data and put them into context in terms of, you know, progression-free survival or survival. Next slide. Efficacy is always one side of the medallion, but we have to know safety. And the main adverse events are actually gastrointestinal in terms of diarrhea, nausea, and vomiting, but also hematological toxicity. And if you look at all patients in all cohorts, almost all patients had some kind of GI adverse event. And this is a relevant issue. And I think with time, we have learned how to better monitor and manage our patients and what GIT mitigation strategies like the use of anti-diarrheal and anti-emetic therapies prophylactically to better let patients tolerate the treatment. Regarding thrombocytopenia, grade 3 or 4 is again occurring in around 1/3 of patients. And anemia, well, just as a reminder, patient characteristic, 60% of patients had NF-related anemia at baseline. And nevertheless, we do have also transfusion dependency and anemia occurring under treatment. And this is most surprising, around 30% of patients. But I think anemia is not a big issue. Thrombocytopenia should be looked at, especially in the early phases of treatment. Neutropenia, leukopenia could occur, but this is a smaller issue in the majority of patients. Next slide. And again, the tolerability was best for the 240 milligram 7 days every 4 weeks cohort. And nevertheless, if you look carefully, in most patients, actually, we needed some kind of dose reduction or dose interruption. And the withdrawal was rather high, mainly because of adverse events or investigator decision. As I said, we are learning to better mitigate, particularly the GI adverse events. Next slide, please. With this, I will come actually to the summary of the data. The 101 trial is actually the first clinical proof of concept study showing the important role of MDM2 and its inhibition in patients with myelofibrosis. And Navtemadlin has demonstrated a dose-dependent relationship for both safety and efficacy with some promising clinical activity and tolerability in patients, again, refractory or relapsed MF to JAK inhibitors. And clinical measures, biomarkers of myelofibrosis disease burden support Navtemadlin at, as I said, 240 milligram day 1 to 7 every 4 weeks as the optimal dose and schedule for patients with myelofibrosis, and the reduced driver allele burden, peripheral CD34 cell counts correlated significantly with spleen response and symptom response, as well as the cytokine reductions. But again, as I said, phase 2 trial, and we always need to have the data of a large phase 3 trial to confirm these data and to show the potential of disease modification, but also clinical response, quality of life of patients with MF. And with this, I would like to thank you very much. And I think this is my next slide. Thank you very much. And I will give back to Laura. Thank you.
Awesome. Thank you so much. So I want to first remind everybody that any questions that they have, we'd love to have you put them in the Q&A. We have one that, that we'll get to, but first, Dr. Al-Ali and I will discuss a little bit about our view about clinical practice, and then we'd like to open up the remaining part of the webinar for questions from all of you about this medication, and we'd be happy to talk about its role, we think, in the overall treatment trajectory of patients, or other questions that you may have in the Q&A. So I want to start here and talk a little bit about when you think about putting somebody on this trial, is there kind of a phenotype, a general patient that you think about? I often have to remind myself that this trial has to be considered before people get too cytopenic, meaning that their platelets have to be above 50,000. What do you think about when you're sort of looking at patients overall and saying who would be the right person for me to screen for this one?
Yes, I think from my personal experience that maybe those really truly refractory patients, you know, in the meantime, we have many JAK inhibitors and stuff like that, and we use these sequentially. And then you are left with a group of really refractory resistant patients who are really not responding to any JAK inhibitor. And this is particular, and in this group of patients, really, we have the best experiences. Patients get hopeless, and you know, we have now also a running trial in combination. We use Navtemadlin with BTK inhibitors, the Telios. And, you know, really, we do see, as I said, very dramatic responses in some of these patients, although sometimes the management of these patients, because of the very high burden of the disease in the beginning, is not really easy. As I said, the GI symptoms, all the MF-related problems, and then treatment itself, it's not that easy, and we really need to look at them. But this is, for me personally, the ideal treatment option. We have to wait to be confirmed in the phase 3, sure.
Of course.
But this is all the personal impression I have. So I think that this is really a good niche, particularly for these very resistant patients, and particularly those also with higher blast counts. And again, we are treating, you know, trials patients with secondary AML transforming from MF with Navtemadlin. So I think this is the potential. If this is, you know, translates into improved survival, and so we have to.
Of course, of course. So let's talk a little bit about the phase 1. What were the dose-limiting toxicities that were seen with the when it was given more frequently than, or was given for a longer period of time than just the 7 days?
Yes, it was, as I said, the GI toxicity, but also thrombocytopenia. Thrombocytopenia is very, very important issue. And as I said, a patient, even with normal platelets, could have a grade 3 or 4 drop in platelets, and relatively fast. So that's why we have to really watch these patients actually weekly at the start of treatment.
And then what do you do to prophylax against the GI toxicities? Are you giving people prophylactic anti-motility agents? anything like that?
Well, that's what we are doing for all patients, at least in the first few cycles. And sometimes just some patients tell me, I didn't take it because I was waiting until, but just the feeling that these patients know about it. I think education of patients is very, very important.
Mm-hmm.
And, you know, the feeling that patients are having anti-emetic treatment and that they are aware of it, it has a big impact also on the psychological effect, because we know some of the issues of nausea and vomiting is even centrally mediated. We don't give prophylactic antidiarrheal treatment, but we give them the prescription. We tell them about that to report to us. And I think with this management, many of the GI toxicities could be really mitigated and patients can tolerate the treatment.
When we think about the mechanism of action, you know, we saw the data that the CD34 count is going down, and that may parallel the decrease in spleen size. We know extramedullary hematopoiesis in the spleen, maybe where some of those are being released into the circulation. So it makes sense that they're going down together. I'm really interested in what it would take for you as a translational scientist to understand if disease was really being, if the clone was really being affected, if things were really reversing. Is it just the VAF level, or is there something else you'd like to see in those patients if you could do as many correlative studies as you'd like?
Well, yeah, correlative studies. The question is what, I think survival, disease-free survival, and these are the really hard endpoints. Because, you know, as I said, I even didn't show the fibrosis data because this really, even the allele burden, with all the respect, we know very well that many patients with MF, when they transform to AML, they transform from a JAK2 unmutated clone stem cell, right, and not from the JAK2 mutated cell. So for me, it's always, what is the meaning? What is the meaning of reduction in allele burden? Or what is the meaning of reduction of myelofibrosis, of fibrosis in the bone marrow? I don't know, I'm not sure. I want to see my patients surviving, and not only surviving just somehow, but with a good quality of life. And that's, I think, are the final endpoints. You could never convince me personally with an allele burden reduction. And, you know, I don't want to remember the stories where we sit and see all these beautiful data, preclinical, and then, you know, the drug is toxic. So it doesn't help anybody.
Right. I do think that I think it's interesting that the correlation between the allele burden and the spleen size seems to matter. And what that says to me also is that spleen size reduction as a fast clinical measurement in a lab makes sense, because it does tell us about a little bit more about response than just the size of the spleen. It may tell us about the change in the overall number of circulating CD34 cells, which we're not necessarily seeing on the clinic in a daily basis.
Right.
One of the other things for clinical practice that's been important here, and I think this is something that's changed over the last 5 years or so, is it used to be when we only had one approved agent, for example, or 1 or 2 JAK inhibitors, that understanding, it was not as essential to understand which patients were relapsing because I didn't have a great next step. For example, if somebody's spleen grew on ruxolitinib, but they were still feeling well, there's not as much of an obligation to measure that out and really document it as well. But now that we have so many next agents, either some approved by our regulatory agencies, many in clinical trials, it's really important for clinicians to be more vigorous about documenting both the status of patients on standard of care, so that we can then know what happened in a regulated way and allow them to be eligible for those studies that come down the road.
Yes, and I always ask, why should we wait until a patient gets so refractory that nothing works? We know this from all our other hematological diseases. And I think the strategy, or we have so many trials, and I believe that something like the add-on strategy, suboptimal response. Even with Navtemadlin, we have a clinical trial. You know, we use a JAK inhibitor as a backbone, wait for 3 months, see how the initial response, how the tolerability, and then put a second class of treatment. And this is what I believe might go into the future, and that this will be the future of management of most of our patients with MF, and not only waiting until they, get so refractory, get so cytopenic that, are not having a real good prognosis, and, many drugs could not be used anymore. So I think we should be now.
I agree 100%. I think we need to be much more vigilant earlier on about understanding who's going in the wrong direction and taking them off before they get too sick for our next studies. So we're going to open up now to the question and answer. We just have one question in the chat, but we'll start there. And I just want to continue to invite people to put their Q&As in the chat. We have a question here. When should we expect the results from the phase 3 BOREAS studies to be released? Do we have any timing on that?
No, not yet, because the trial is still actively enrolling, and I think it will take some time. But I could say that the manuscript will be for the phase 2 trial, and also an overview of the phase 3 trial is in preparation and will be hopefully published soon, so that one can read all these results.
That's great. Another question is sort of this from the same person who brought this up, is that how, and I'll just rephrase this a little bit, how do you talk about when you're talking to a patient, for example, about multiple trials, how do you couch the activity of a medicine like Navtemadlin versus the other options that patients may have in second line, like pelabresib or navitoclax? When you're thinking about that with a patient, how do you talk about this agent versus those others?
Yes, I think this is a very important issue. I always, if I have more than one option, let's say approve plus clinical trial for this particular patient, I discuss both options with this patient very open, and don't try to push my own, my own opinion or my own idea on the patient, because I always say, especially in the context of myelofibrosis, we have learned how many phase 3 clinical trials have failed for one reason or another. And I'm very open with the patients. I give them time, give experience, give data available to phase 2, and really let the patient, sure, with my advice, make the decision for him or herself, because at the end of the day, we don't know how the results of these ongoing trials will be.
Mm-hmm. Yeah, that's my approach as well. I like to also list the goals of the patient. So is your goal about feeling better? Is your goal about cure? Is your goal about not needing to come in as much for transfusions? And I try and clarify which approaches have the best data to accomplish their particular goals. I think that keeps the patient experience front and center in the decision making, and also allows you to kind of allows them to think about it in a more systematic way sometimes. So another question that came up with me is, I was very interested in whether or not this agent has, if you know of any experience with this agent, with some of the other, either an MCL1 inhibitor like a hypomethylating agent, or the BCL2 inhibitors, for example, venetoclax. Has there been any combinations that include those agents? And do we know anything about whether or not combos may synergize with the apoptotic pathways you were describing?
Yes, indeed, a very good question. Hypermethylating agents, there is a trial going on in patients with AML, refractory, second-line treatment, where hypomethylating agents and Navtemadlin are combined. We have ourselves treated a patient in this trial, but we have still to wait for the results. So indeed, and I myself love epigenetic modulation, because I think everything is epigenetics. And as I said, with an MDM2 inhibitor, I think it is a very nice and very promising combination. Let's wait and see what the results of the trials will be.
Yeah, I think that especially when we're looking at that very tough group of patients, the patients with an increasing blast count who may or may not have the absolute phenotype of AML yet, that's something where we need to pay really attention to using agents that could really increase apoptosis on all the different pathways. So patients that go into this study have to go through a screening that would clarify that their P53 status is wild type, not mutated. And maybe we could just talk for the audience a little bit about why that screening step is essential for using this drug.
Yes, I think it is a very simple explanation because, when we inhibit MDM2, the idea is to restore a normal P53 function, tumor suppressor function. But if we have a TP53 mutated gene, I cannot restore a normal P53 function by just suppressing MDM2. And, in clinical practice, it was tried over and over again in cell lines, animal models, and even in the trials at the very beginning to include patients with TP53 mutations, but no surprise, it didn't work.
Luckily, only about 10 to 15% of patients with myelofibrosis have a documented P53 mutation, which means that we're not going to lose out on too many patients because of that particular screening step. We do have a question here in the chat, wondering if you could update the audience on the KRT-232-114 study, which combines Navtemadlin with TL895.
Yes, as I said, I just mentioned this trial. I think we're talking about refractory patients. Yes, I mentioned this trial, and I have a patient now being treated in this trial, but we are still very, very early. We are still in the dose finding. So, and I don't know, I'm very excited. We have the monotherapy with the BTK inhibitor, and we have this combination. We had the BOREAS trials where we had the mono treatment with the MDM2 inhibition. So it is quite exciting, but it's much, much too early.
Of course.
The patient is doing very fine, but it's too early.
Right. I think the translation of the BTKs, the BCL2s, the MCLs, even the HDAC inhibitors, synergizing with some of these other agents is really an exciting next chapter for treatment of primary myelofibrosis. So I'm excited.